Good afternoon and welcome to our seminar on optimizing health policies with a somewhat provocative subheading, Are Tests Overrated? That's the topic for today, and I'm really delighted that you could join us. First of all, let me start off with the introduction. Your hosts today are myself, Stefan Conradi, and my colleague Stacy Blodgett, who is joining us from Missouri today. And even though you may not hear her voice throughout the presentation, you will probably receive from her any responses to questions you may post today. So with that, let me proceed to our objectives. The first objective, a methodological one, we want to talk about how Bayesian networks can be used as a framework for reason about health policies under uncertainty. So that's the first one, and the second one is our substantive research objective. That will be all about establishing optimal policies for malaria and pneumonia diagnosis and treatment, meaning we want to distinguish or determine whether a test and treat policy or a presumptive treatment policy is most appropriate. So, more specifically about the flow of today, we will start talking a little bit about the motivation and the background for the study, over and under treatment of malaria and pneumonia. We'll talk about the testing guidelines of the World Health Organizations. And then next thing is to discuss methodology, how we're going to approach this topic, given that there is very little data on this particular problem domain. And then finally, and this will really be the biggest part of the webinar, we will talk about the actual workflow. We will encode domain knowledge into a Bayesian network, we'll elicit probabilities, we will look at costs and utilities, and finally, this will be the ultimate objective, we will search for optimal policies. I would expect that we need, for the first part, perhaps just under 30 minutes, and then have 30 minutes for the main workflow. Now, in the course of today, we will primarily see BayesiaLab in action, our principal piece of software, and we'll also catch a little glimpse of the Bayesian expert knowledge elicitation environment, but that will just be a very brief reference. Just for your information, all the slides that you will see, plus a recording of today's webinar, will be available. I'll post the link after the session. The webinar will be posted on Facebook, YouTube, etc. So you can watch it via many channels. So what brought us to today's topic? Well, I came across actually two articles in the Malaria journal. And what was interesting about them that they both seem to recommend different policies with regard to malaria testing and treatment. So they were just a few years apart, but they really were kind of sending kind of different signals about how to go about this. Now, as we enter the discussion about health policy, I should state an important caveat, and that is this medical subject matter is strictly for methodological illustration purposes. So our problem domain today is, of course, infectious disease diagnosis, but that's really just a prototypical example for diagnostic inference. Also, the way we present this topic is highly simplified. So this is by no means exhaustive, and you should certainly not look at what we share as medical research or a health policy recommendation. We're strictly trying to illustrate a methodology. But let's talk about the principal subject matter, and it is quite a serious matter in the sense that infectious diseases in sub-Saharan Africa cause over 4 million child deaths annually. Of those, over 1 million are due to bacterial pneumonia, and over 750,000 are due to malaria. So now, really what is quite sad about this situation is that economical, efficacious treatments are available. Antibiotics in the case of bacterial pneumonia and artemisinin combination therapies for malaria. So why are those not employed or utilized? Well, one of the challenges is that those diseases, pneumonia and malaria, have very similar symptoms, and the diagnostic tools available to healthcare practitioners in developing countries are very, very limited. Typically, the only measurement they can take is the body temperature. Of course, in developed nations, the situation is quite different. Here, for instance, for pneumonia, X-rays are one major tool for diagnosis. You can easily detect pneumonia on a chest X-ray. Malaria, similarly, there is a gold standard for its diagnosis, and that is a microscopic diagnosis. And here, this image here shows a blood cell with the malaria parasites. So that can be clearly and reliably detected with a microscopic analysis. Now, it's not hard to imagine that these technologies are not available in many developing nations. And so for quite a while, the diagnostic approach really was that if a patient had a fever, it was presumed to be malaria, and they were given anti-malarial medications. Now, with that, the problem was malaria was really overtreated, and conversely, some bacterial infections, such as pneumonia, were missed because any fever was automatically interpreted as pneumonia. So, now that has changed a little bit as new diagnostic technology became available. And in particular, there was what is now known as a rapid diagnostic test that allowed really with just a few drops of blood to detect whether the malaria parasite is present. Given this innovation, the World Health Organization recommended that this test should be used very widely, and in fact, every suspicious case, in any case where malaria was suspected, that test should be applied. So, and this was on the surface really quite a successful program, because over the last decade, from initially just 200,000 diagnostic tests being distributed worldwide, this grew to over 50 million by the year 2010. So really, if you think about a program and its impact, that is huge. But now, roughly a decade later, some concerns are emerging as there seem to be some unintended consequences that, as the name implies, were not expected. So what were these consequences? The problem was that, in a way, after such a test, such a rapid diagnostic test ruled out malaria, people were often prescribed antibiotics. So what happened is that in a way, we traded the overuse of anti-malarial drugs for the overuse of antibiotics. And you can perhaps imagine how a healthcare provider, a mobile clinic somewhere in Africa, when you have a patient who perhaps walked for miles and miles to come seek care, and that then you feel compelled to provide some treatment. So if you rule out malaria, then perhaps the next best guess is pneumonia, and you prescribe an antibiotic. So Now we want to really understand what is the mechanism of this unintended effect. Why do things go wrong in this way? And what it boils down to, that human reasoning is flawed. And please don't get me wrong, I'm not talking about poor reasoning in poor countries. This is about poor reasoning in general. As we sit here in our comfortable offices with fancy computers, we are not immune to poor reasoning. That is very important to understand. And we talked about this topic over the last couple of webinars, but I want to reiterate that. And I want to really emphasize the human cognitive limitations, especially when we reason under uncertainty. Now, there's one area where our reasoning is actually quite good, and that is when we reason from cause to effect, such as if we were to reason from a disease to a test, to the test outcome. The test is the result, the effect of the disease, which is the cause. And for instance, if somebody told you a test has 99% accuracy, then we know if the disease is true, then the test would have a 99% probability of reporting that correctly. However, things start to fall apart when we reason in the opposite direction. And you may recall the exercise that we did in our webinar on March 2nd, a very simple reasoning example. And there we had people who participated in a webinar about reasoning in a very simple inference exercise, and 70% of the participants got the wrong result. So I think this was quite an eye-opener, and that certainly makes you appreciate, if we can't get it right in a sort of a very nice environment under ideal conditions, how difficult it must be for a healthcare practitioner elsewhere in the world to do that. So, but the case here is actually a little bit more difficult than what we presented in the exercise. So let's go through reasoning about an individual case. Let's imagine we're looking at a patient who presents himself with fever. So the first variable that we observe is fever equals true. So given that there is now a possibility of this patient having malaria, we want to administer the rapid diagnostic test for malaria. But of course, the other cause for the fever could be bacterial pneumonia. In fact, there could be many other causes for the fever, but for the purpose of this presentation, we'll just talk about those two causes. So let's say we now have the suspicion of malaria and we apply the test, and that test comes back negative. We would obviously reason from the effect back to the cause and update our beliefs with regard to the cause and say, given that the test is negative, probably there is a much lower probability that the patient has malaria. But it doesn't stop there. Rather, we would quite naturally continue our reasoning and reason via fever back to bacterial pneumonia and infer that this is now more probable. We're kind of explaining away. We're now looking at, given that malaria was probably not the cause of the fever, we're observing fever, most likely bacterial pneumonia is the cause. As a result, we would probably not treat for malaria and probably do treat for pneumonia. But that's where we can run into problems. While the qualitative reasoning I presented here is intuitive to us, and that's how there's nothing challenging about that. The quantitative part, that's the tricky part where we can get things wrong. As the exercise 2 weeks ago highlighted. So here, for instance, if we wanted to reason about pneumonia, given a negative malaria test, let's think about now that we have a given prevalence of malaria, we have a given sensitivity and specificity of the rapid diagnosis test, then we can compute how the probability of pneumonia is a function given the prevalence of malaria. So in case, for instance, we have a very low prevalence of malaria, then the diagnostic test would indeed raise the probability of the patient having pneumonia to over 50%. But if the prevalence of malaria is higher, if we get into this range, then even though the test suggests no malaria, it doesn't lift the probability of pneumonia beyond 50%. So that makes it tricky to infer, well, is it really pneumonia or not? So where do we go from here? How do we resolve that? Well, somebody might say, you know what, why don't we test for both malaria and pneumonia? Now I should point out this is a somewhat hypothetical example because really a proper pneumonia test is not commercially available or readily available in a way that it could be used in the field. But there is conceptually a test that actually measures or that reflects inflammation, which in turn has diagnostic value for pneumonia. Excuse me, that's a so-called CRP test. And one could imagine that one day that might be available for testing in developing nations. So now the question is, should we pursue that? Is it even plausible to pursue that? Should we aim for or consider a policy that would essentially say, for malaria, shall we test and then treat, or should we automatically just pursue presumptive treatment? And the same thing for bacterial pneumonia. Should we pursue test and treat, or just give everybody who comes in with a fever, just give them antibiotics or give them anti-malarial drugs and antibiotics? Some have advocated that. Now, of course, this is a big question, and there are many other things that go into the equation, such as the cost of tests, cost of treatment, limited resources, obviously, unintended consequences, overtreatment of malaria, overtreatment with antibiotics. You all know about antibiotics resistance, that's a big topic, and so on. So, and you may ask, well, how can we reason and establish a rule for the entire world if we can't even reason correctly about a single case? So how is that possible? How can we even proceed from here realistically? Well, perhaps in this day and age, we may be tempted to say, well, let's just collect all the data we have and build models and simulate these different conditions and treatments and diagnostic tests. And certainly here in the US, for instance, we could explore millions and millions of patient records in this regard and look at diagnostic codes and treatment codes and so on. But unfortunately, for the part of the world where we would want to apply this policy, we have little data. We're very far away from big data. So because few patient records exist and diagnoses may not be recorded or patient records may not be kept, etc. So it's very easy to envision that there is not a lot of documentation. So that's where Bayesian networks must come in. And I'm starting off here with the map that you've all seen. If my slides were to move forward, here we go. This is a map of analytic modeling and reasoning. Just as a recap, here on the x-axis, we have model purpose that ranges from association to all the way through causation. And then on the y-axis, we have model source ranging from data or on the one side we have data, on the other side, on the other end we have theory. So here in this case, clearly we have no data. We need to purely reason on theoretical grounds. We've done that before. In the past 2 webinars, in fact, you may recall the reasoning about the cab color or reasoning about the lost luggage, but we had relatively few variables and it was certainly a much simpler domain. So here is the approach we're trying to pursue today. We will take this step by step and in a much more compartmentalized way. We'll start off with encoding our domain knowledge. We'll think about what relates to each other, with each other, what is cause, what is effect. Then as a next step, we need to elicit probabilities, and those we can potentially get from various sources. Perhaps there may be some data, perhaps we have some values from literature, perhaps we can run a small experiment, or we rely on domain, on expert knowledge. Then, and this is something we only very casually touched on in recent webinars, we need to look at cost and utilities. What is the cost and the benefit of individual treatments, cost of diagnosis, and so on. And then finally, as a separate distinct step, whereas everything else, what we've collected so far was our human input, our human thinking, that last step, that's all about optimization. So, and that part really is what BayesiaLab will provide or compute for us. But important here is we have a we have 4 very distinct steps, and that also helps us to really bring in different stakeholders for different portions of this process. So with that, I would like to proceed to building that model, building a model of the domain. And we're really now following the approach that we first proposed in the last webinar. However, clearly we're not in a work group here. I'm kind of simulating to a work group here. It's just me, myself, and I, and you will now hear me think out loud and listen to expert advice from myself. That's how we're going to build this model. So let me now pause my screen sharing and switch over to BayesiaLab. Good. All right. So now we need to encode our problem domain. And let me perhaps start with the most obvious variable, and I will create a node for malaria. And while we are modeling a node for malaria, we need to realize we will probably observe that in 2 time periods. We want to study that in time t0 when the patient presents himself for the first diagnosis, but then also later at some time period t2. So I'm just copying that, or not t2, rather t1, where we can, which will represent whether or not the patient has recovered or not. So these are kind of our 2 time slices that we want to consider. Okay, now when I speak of the diagnostic test, malaria is unfortunately not directly observable. Rather, what is measurable is the presence of the Plasmodium parasites. So there are, in fact, I think 4 different species of parasite that lead to kind of a special kind of malaria. But here, for simplicity's sake, we're simply looking at that group of species as a whole. So those parasites are clearly the cause of malaria. Another thing we want to take into account is the malaria prevalence, because that can be very different depending on the region, the season, climate conditions, etc. So I'm creating here a causal relationship between malaria prevalence, the presence of the Plasmodium parasite, or rather the probability of the presence of the parasite, and then the malaria itself. Bear in mind, there are lots of Plasmodium carriers who may not immediately develop any symptoms. They may carry the parasites for their entire life without ever getting sick. So I said our rapid diagnostic test can diagnose or can detect the Plasmodium parasites. So I'll call this rapid diagnostic test. Okay. And if we follow the logic of the World Health Organization guideline, then whether or not we treat malaria should be a function of the test outcome. So I will create a node that I call ACT treatment. That's the combination treatment that I mentioned earlier. And this treatment, whether or not that is being performed, would be a function of the rapid diagnostic test. Just fix the typo here. So, and furthermore, one could argue that malaria, or malaria at time slice T1, the final state, is related to the state of T0 and on whether or not malaria is being treated. So that's what we have so far. And very importantly, we also need to add one further node, and that represents symptoms. In fact, the only symptom we will consider here is fever. And I'll call it fever at T0. And similarly, I will also create, I'll just copy and paste this node, a fever at T1. I will link malaria T0 to fever T0 and malaria at T1 to fever at T1. So now we really have our original reasoning framework. That's probably what the World Health Organization had in mind as to how we would reason about malaria. The logic was we do the rapid diagnostic, or we start here, we observe fever of the patient. Given the fever, we run the rapid diagnostic test. That informs us about the presence of the Plasmodium parasites. They, in turn, we know are the cause of malaria. So that would be our reasoning framework. But now, as we said, we need to extend that because we had these side effects, these unpleasant side effects, or side effects or unintended consequences, I should rather say, because bacterial pneumonia was beginning to be overtreated. So I want to add almost a mirror image of this structure and add that to the other side, starting here with bacterial pneumonia. Again, I'll do that for T0 and then replicate that for, I'll just do Control C and Control V to create copies. Once again, we have a relationship between T0 and T1, and of course we know that bacterial pneumonia causes fever, or fever is a symptom of bacterial pneumonia. So now our proposal was, well, what if we could test for pneumonia? So I'm now hypothetically introducing a CRP test. This is what we think could help us diagnose pneumonia. So with that, we need to draw an arc from bacterial pneumonia to CRP test, and that should help us determine whether or not we should pursue an antibiotic treatment. And even though very few of us who are participating today may be doctors, I think the logic here is fairly straightforward and plausible. And even for us non-experts, we can reasonably participate in the rationale we present here. I think this is one of the attractive things of Bayesian networks, that it is very, very explicit and straightforward. And for those physicians who are participating in this webinar, they can look at this and immediately say, yes, that reflects our domain knowledge, or no, this is something important is missing here. Now, chances are that something important is missing here, but really the point is that Bayesian networks are very, very practical and an intuitive representation of a problem domain. So, antibiotic treatment, we would think, has an impact on whether bacterial pneumonia is resolved. So we have this part here. Okay, so this seems plausible now. We should almost be ready to reason. Of course, what we don't have yet is all the probabilities. You see all these yellow warning triangles, they tell us kind of what is not, where the conditional probability tables have not been defined yet. And unfortunately, we don't have enough time to go through all that. So I will continue with this network and then switch to a network where all these probabilities have already been elicited. Otherwise, we will probably spend the rest of Friday afternoon finishing this network. So, but here is now really the critical element. So far, this is just reasoning about the presence and absence of malaria. Now we want to get into the policy part. And before we can consider, let's do that now. And I will introduce a policy, a decision node in BayesiaLab. There's a very specific kind of node that has this square shape, and that serves as a decision node. And BayesiaLab can experiment with the states of such a decision node in order to pursue an optimal policy. So I will open this node. By default, it has two states, decision 1 and decision 2, and I will replace these states with test and treat as the first policy, and then secondly, presumptive treatment as the second policy option. So, and later on we will do the same thing, or perhaps we can copy that so we can paste it into the other policy node straight away. So that's my malaria policy, and then over here on that side I will create a node for antibiotic policy. So I've just pasted the same two states into this node. So how do these policies now interact? Well, very straightforward. These policies determine whether or not a treatment happens as a function of the diagnostic results. So how does it work technically? Well, it's very simple. We can enter a probability distribution here. So I'm just opening up the node editor. And this now tells us whether this is for the treatment node. And this now tells us, or we need to now define whether treatment happens given presumptive treatment and given test and treat policy with the test results. So this is quite easy to fill out. I would say if we have presumptive treatment, then it's always 100%. Treatment is always true, the 100% probability. In the case of test and treat, we would only have treatment in the case of a true test result. So only this one would be filled in. And perhaps we set that to 95% or so. Who knows what the adherence is to the precise protocol, whether they follow the test results, etc. But here we can encode the logic of we only treat if we test and then get a positive test result. So that's encoded in this node, and this is kind of the critical part. Another important node that we should look at, and I should really spell it out before we proceed, is the node that we have here, the type of node. Because it is very clear that we have many other possible causes of fever. I mean, there's so many tropical diseases, there could literally be hundreds of other causes. And clearly we can't imagine and enter all these other possible causes. And with that, our network would be limited. So here's a trick how we can overcome that. We can introduce a noisy OR node that allows us to model kind of everything else, all the other possible causes without really specifying what they are. This makes makes the representation of a conditional probability table easily possible. So let's do that. We can grab this from the bottom panel on the left. I can select my noisy OR node. I specify which node I'm considering here. Here, this is about fever. Fever is the result. Then there is a parameter for leak, indicating what could leak into this node from other sources that we have not specifically specified. Then I'm selecting malaria as a cause, bacterial pneumonia as a cause, and the probability that these causes individually would produce a fever. And I'm just making up values right now. Obviously, there are probably studies and literature, and one would have learned in med school what exactly those probabilities are. So with that, I've now defined the node fever with this noisy OR statement in the node editor. That's quite important. Okay, we're making good progress here. Now the next step is we need to specify costs and utilities. And there are quite a number of them. And BayesiaLab has a special type of node, this diamond-shaped node, that allows us to associate certain values, costs, utilities with the states of nodes. Perhaps let's start perhaps here with the ACT treatment cost. That's a very straightforward one. And just label this appropriately. I will open up this node, and now I can say, what if ACT treatment is false? What is the utility? I would say 0. It doesn't cost anything. If ACT treatment is true, I'm saying the cost is $1 or whatever currency. I enter -1, a negative utility. With that, I have the first utility defined. Now, the second one, that relates to the cost of the test. And I think in this case, actually, the test is more expensive than the treatment. I don't know what the exact values are, and we don't need to go into these particular details, but this is one of the things that plays into it. Is actually the treatment more expensive or the test, and how should that determine whether I test and treat versus apply presumptive treatment. Now, the way we handle this here, I make my test cost a function of the policy. And because the test only applies, the cost of the test only applies for those who show symptoms, who have a fever, therefore I make RDT cost also, or link that also to fever. With that, I can now say, let me arrange it this way. So in the case of no fever, utility is 0. They wouldn't even be tested. And in the case of test and treat, we would have the cost of the test. In the case of the presumptive treatment, we wouldn't have a cost, obviously. So I can just very concisely enter that here into this table of the node. And we have 2 more to go. We have the antibiotic treatment. Follows the same logic. I connected, hold on, not quite, I jumped ahead. I wanted to do the CRP test cost first. And the CRP test cost is a function of the policy. Do I test and treat or do presumptive treatment? And of course, this would only apply to those who show symptoms. Now, this one is an interesting one. That's why I've saved that for almost last. That is the antibiotic treatment cost. And there is a special twist to it, because with antibiotics, there is also a risk of overtreatment, or there are some potentially serious consequences of overtreatment, like antibiotic resistance. And so this certainly would produce a cost, an economic cost for the healthcare system, etc. So in this case, I will not only account for the cost of the individual's antibiotic treatment. So here I could say, so if bacterial pneumonia is present, I will, if bacterial pneumonia is true and I do antibiotic treatment, I have a cost of $1. But perhaps, and this accounts for this potential overtreatment cost or the consequences, what would be the economic implications if the, and actually you need to go up one note, if the bacterial pneumonia is false and I still treat? So that's the issue. That's the potential overtreatment risk. So I'm making up a value and I say this has a value, a utility of -2. So now I have defined all the probabilities, and now there is not probabilities, all utilities, and there's one more to specify, and that relates to fever, or I'm linking that to fever as a proxy of whether or not the patient has recovered, whether whether the illness has subsided or whether it persists. So this is obviously not necessarily a question for the physician or the healthcare worker. This perhaps is more a question for a healthcare economist, saying what is the cost to society, to the healthcare system, if a patient recovers or does not recover. So I'm just arbitrarily making up a value and say the recovery, or I can make that a positive value and a negative value to represent the positive versus negative impact of recovery versus a non-recovery. Okay, now we have a complete system. As I said, we haven't elicited all the probabilities. Rather, what I'd like to do now is take a finished model where I have elicited all these probabilities, or I shouldn't say elicited, is where I have made up the numbers. I hope I've picked some somewhat reasonable numbers. But now we can try out how that would work in practice, how we would implement that, how we would search for policies. This is how we do it. Let me perhaps bring up first our two policies. Let me bring up the nodes for our two principal diseases. And let me bring up nodes for the tests and for the treatments. And of course, I will bring up one node, one utility node, because in each utility node, I get its individual utility as well as the overall utility, the sum of all the utilities of all the utility nodes. That value I can see in the bottom number. That's the number here that is preceded by the sum sign. So we will keep an eye on that as we go through different scenarios. And one more thing I want to do, I will fix the prevalence, the malaria prevalence. So, and here, and this is an important element, because as we develop this policy, we have a high degree of uncertainty, because this policy is supposed to apply across continents, across a wide range of conditions, and we may potentially have very, very different levels of malaria prevalence. So here I'm applying a uniform distribution across low, medium, and high. Again, the thresholds are arbitrarily selected. But what we want to do now, given all the probabilities we entered, we can now let BayesiaLab look for what is the ideal policy. Is it better to test and treat, or to apply presumptive treatment? Okay, here's a function you may not have seen yet in BayesiaLab. It's called learn static policy. This is now will essentially try out all the possible combinations of policies. And here we have only two policy nodes, but you could have many, many more. And sometimes that learning then might take longer. But let me run this now. Let me click Learn Static Policy, and keep your eye out on the two blue boxes, the two blue monitors in the monitor panel on the right, because you'll see what happens as we learn the policy. I click Learn, and you see that the aqua colored bar has switched. This is now what BayesiaLab recommends as the policy. So the recommended policy that maximizes the utility is apply test and treat for antibiotics, for bacterial pneumonia, and for malaria, use presumptive treatment. So depending on the disease, the recommendation is for different policies. But that was under, if you will, perfect uncertainty, where we really don't know what the malaria prevalence could be. However, if we knew it, let's say we are, in the dry season, and in a certain part of Africa where there's just a low malaria prevalence, we could reevaluate this policy specifically for those conditions. So let me set malaria prevalence to low and run the static learning policy again. And given a low malaria prevalence, I now have a policy recommendation that says test and treat. If I were to switch to malaria prevalence high and learn the policy again, then we would be back to the presumptive policy. It is very interesting that this came out here, because several articles in literature have specifically recommended that approach. For low prevalence situations, test and treat. For high prevalence situation, simply apply presumptive treatment. And of course, as I said earlier, this is still highly simplistic, and a lot of considerations are missing here. But I think it illustrates how a framework like that can help us reason. Now, on this basis, we can spend energy on eliciting probabilities, add other relationships, and so on. And with each iteration, get to an improved model and perhaps to better policies. Just one thing I thought I should highlight here. Where's fever? Oh, I haven't shown fever yet. Fever. Let me now simulate a situation where we have fever at time frame 0, patient has recovered at time frame t1, just to give you a sense of how much reasoning has to go on in this system. Let's just take this example, reason from rapid diagnostic tests, or rather highlight the influence paths. This is a very helpful tool because it can show us how information, what is the correct normative progress of information in a network to update probabilities. And in this particular case, you see that there is 7 paths, 7 information flows through the network that are in a way required or that have to happen in order to compute a probability. So in this case here, I'm inferring the probability of bacterial pneumonia given the observation of the rapid diagnostic test. So this is kind of was the starting point of our discussion, where we thought the reasoning about bacterial pneumonia is problematic. And now we can see how, as we expand this model and take into account more and more elements, there are in fact lots of paths, lots of influence paths that all have to be computed in order to arrive at the correct inference for bacterial pneumonia. And needless to say, none of us can do that in our heads, and therefore we must encode our problem domain in a framework of this kind. So with that, I will close out of BayesiaLab, and if GoToWebinar allows me to do that, I will briefly switch back into PowerPoint. And in the slide deck that I will share with you, I have quite a number of screenshots that you can, so you can kind of follow along and see some of the details that perhaps I failed to mention. Okay, so, and you may look at this and say, well, this all sounds terribly familiar. Isn't this exactly the same thing that we did before, albeit it may have been a bit simpler? Yes, indeed. Really, it all boils down to very similar structures, and the problem of inferring the color of the cab, the problem of inferring whether we will get a bag or not, the problem of assessing the risk of getting a speeding ticket, they all follow the same structure. And once you're familiar with the Bayesian network framework, it becomes remarkably simple to capture any problem domain and represent it and solve it in that way. So let me just wrap things up. I think I have just 2 minutes left. A lot of the questions and answers related to our webinars are posted in our user forum. In fact, all the questions that have come in, we will repost on the user forum and also provide our answers. So hopefully we will have an interesting discussion there. If you're interested in using BayesiaLab for your work, please take a look at our website. And of course, what you've seen here, you can immediately replicate yourself. We have trial versions available, and so you can follow along with the video and replicate the very same model that I just produced. Now, next week we continue with our webinar series, but then for once we won't have a medical topic. Rather, we will talk about a marketing science topic, product substitution and cannibalization. Very important topic, very poorly understood, and I think we can share some ideas as to how we can make the approach to this topic much better and, most importantly, much easier. Now, before I finish, I should highlight our courses. Our next one is coming up in April in Sydney, Australia. After that, we return to the US, including our rescheduled course that will now be in San Francisco, July 23rd through 25th. We have a fantastic venue there. San Francisco is obviously a great city, so please think about joining us for this course. And again, you've probably heard this numerous times from me. Please consider joining us for our annual BayesiaLab conference that will take place in Chicago this year. We have a great location right off Michigan Avenue. Should be, honestly, a lot of fun. I think it will be a great event. With that, thanks a lot. I appreciate your patience during the technical glitches, and I hope you can join us again next week. Here are all our contact details. Please feel free to reach out with any questions. And so, thanks again. Have a fantastic weekend.